classification. So I think you, in this case, thank you, Professor, for the honoring my invite. Sorry for the delay. We have a bit of technical issue. Our projector has malfunctioned. So we can start the discussion because of time. Okay, I think most of you attended this meeting or this discussion because you saw the flyers that were circulating on our social media platform saying that we're going to have an SLE/lupus nephritis case discussion today. And that is our agenda for this. So the outline of the history of biodata, presenting complaint, history of presenting illness, past medical history, family social history, review of system, the summary, the observation/examination, impression, and diagnosis, and potential investigations and management, the discussion and the conclusion. So our question today is HW, 40 years old female, who resides in Pipeline, is a G4S security officer. She is single with a child, so she's single, she has a child, and was admitted on 11th of February 2024. When we clocked this patient, it was on 6th February 2024. The chief complaint was the patient was admitted to the rheumatology clinic.
Excuse me, sorry for the interruption. Anyone with a laptop in the audience, can you? Anyone with a laptop? Okay, can you?
So the chief complaint, the patient was admitted through the rheumatology clinic in KNH, secondary to low platelet count. So the patient presented with a platelet count of 20. The history of presenting illness, patient is a non-systemic lupus erythematosus patient with lupus nephritis that was diagnosed in 2017 at a peripheral facility with a positive anti-nuclear antibodies and anti-double-stranded DNA. Patient has has been on hydroxychloroquine 200 milligrams, azathioprine 100 milligram, prednisolone 40 milligram, calcium 1 tablet, aspirin 75 milligram, and esomeprazole 20 milligram. She has been on follow-up at KNH every 2 to 3 months. Of note, she was on mycophenolate mofetil since the diagnosis, but then it was stopped in March 2022, secondary to thrombocytopenia. So the patient developed thrombocytopenia, and it was found out that it was the mycophenolate mofetil that was causing it, and they stopped it, and it was switched to azathioprine. Patient was stable until 1 week ago before she came in for her follow-up, where she presented her lab results that revealed a low platelet count. On further questioning, the patient revealed that she had a 3-month history of bleeding tendencies after minor trauma and easy fatigability. The patient reports normal menses. There were no associated bleeding from the gums while brushing, no epistaxis, no hematemesis, no hematuria, no hemoptysis, no hematochezia or melena. Patient described tiring easily when walking that was associated with dizziness and a dull frontal headache that was intermittent in nature, that is mostly occurring in the morning hours, that was revealed by sleeping, no exacerbating factors, and no medication that relieved it. She gave it at 6 out of 10. There are no associated hotness of body, no loss of consciousness, no neck stiffness, no convulsions, and no history of trouble. She also reports no history of palpitations, chest pain, dyspnea, cough, paroxysmal nocturnal dyspnea, orthopnea, or syncope. Patient reports recurrent urinary tract infections that was treated over-the-counter drugs and reports relief, and reports no further history of hotness of body, sore throat, or chest congestion. So the only thing that was apparent on the infections was the recurrent UTIs, no other place for infection. At 16 years of age, she was admitted at KNH with generalized body swelling that started at the face, descending to the lower limbs, with decreased urine output. And the last episode of this complaint or similar complaints was 1 month before admission. At the time of clerkship, she negates any history of urgency, dysphoria, nocturia, or flank pain. In 2017, the patient developed symmetrical joint pain of the hands, wrists, elbows, and knees that were associated with early morning stiffness and subsided with activities as the day progressed, and the aforementioned renal symptoms. Together in 2017, there were symmetrical joint pains that were leading towards arthritis, and together with renal symptoms in 2017. At that time, she had no history of joint deformities, no swellings or subcutaneous deformities. Urinalysis was done in 2017, and it revealed hematuria, red blood cell cast, and proteinuria 2+. At that time, the doctors wanted to cinch on the diagnosis, and they did a renal biopsy at that time, and it showed class 3A and class 5 membranous lupus nephritis. So that is results showing from the renal biopsy. Then a year later, that was 2018, the patient developed cellulitis that involved the lateral aspect of the right leg and was treated successfully as an inpatient for 1 week. Patient also reports history of color changing of digits ranging from pale blue, red, on and off, that was precipitated by cold weather and stress, and she can't recall the last episode she had that. There's no history of rash secondary to sun exposure. There is history, however, there is history of thin, brittle hair that falls off easily when she brushed her hair. There's no family history of systemic lupus erythematosus, no history of discoid rash, no history of oral ulcers. There's no history of hydrolysine or procainamide use, or any drug that precipitates systemic lupus erythematosus. No history of oral contraceptive use, no history of recurrent fetal loss or venous thromboembolism. Reports history of occasional drinking wine during weekends, but negates any history of smoking or use of other recreational drugs. Since admission, the patients they took the blood and urine samples. I think that was the only investigation they did since her admission, just blood and urine samples. And currently, at the time of clerkship, the patient reported nausea that was not associated with vomiting or diarrhea and the persistent headache. That was the current complaint when we clerked her. But however, she reports improvement of symptoms from the time of admission. So the easy fatigability literally went away after the admission. So past medical history, this is her fourth admission. The first admission was for the renal biopsy, that was 2017. The second was the time she presented with thrombocytopenia, secondary to the MMF use, and the third was the cellulitis that I mentioned in the HPI. She has no other chronic medical conditions except the systemic lupus erythematosus. She has no history of previous surgeries. There are non-food or drug allergies. She has no history of any previous blood transfusion, and she is seronegative. Her obs-gynae history, it's quite remarkable, but we can just take you through. She's para 1+0, delivered via SBD, that is spontaneous vertex delivery, in 2014 at Sharon Hospital to a term baby. No neonatal or maternal complications were noted. Her menarche was at 13 years of age. Her menses, as I had mentioned in my HPI, it's quite normal. So she has her menses that last 3 days, it's regular, comes after 28 days. No dysmenorrhea, and she uses 3-4 partially stopped pads. And and then there's no history of oral contraceptives, as I had mentioned earlier in my HPI. Coitaki was at 29 years of age. She reports no dyspareuria, no pap smear done, and no sexually transmitted infections. And she currently, when we were asking her these questions, she was not sexually active. Family and social history: she's a single mother. Her father is deceased due to road traffic accident. Mother is alive and well, has history of breast cancer and hypertension. She's the fifth born of 6 children, and all her siblings are all alive and well, except her eldest sister, who has been recently diagnosed with breast cancer. No known history of any other chronic medical conditions in the family. No history of sudden death in the family. She's a Form 4 graduate, and her NHIF is active. Review of systems. If you're listening to the history quite well, systemic lupus erythematosus is a multisystemic disease. So we covered quite all the major systems in the HPI, except a bit of GI, which we mentioned towards the end that she was complaining of nausea that were not associated with vomiting. Okay? So the review of systems was quite unremarkable. In summary, I'm presenting HW, a 40-year-old female security officer from Pipeline. Day 5 post-admission due to low platelet count was an incidental finding at the rheumatology clinic for her usual follow-up. A non-SLE lupus nephritis patient since 2017 on hydroxychloroquine, prednisolone, azathioprine, aspirin, omeprazole, and calcium, and she's usually on her follow-up at KNH. Presented with a 3-month history of bleeding tendencies after minimal trauma, easy fatigability, headache, no other CNS or CVS manifestations, no history of hotness of body, weight loss or recent travel, has history of intermittence and asaka and oliguria 24 years ago, history of recurrent infections, Raynaud's phenomenon, photosensitivity rash, cellulitis and arthritis. 2017 biopsy showed membranous lupus nephritis. Currently reports general improvement of symptoms but has nausea and headache. General examination, we found a middle-aged woman sitting upright in a fairly good condition. She was well nourished, no obvious respiratory distress. She had an IV cannula on her left dorsum. Bilateral hyperpigmented macules on cheeks were noted, sparing the nasolabial fold, but on the oral, we found some caries, and we advised her to go for dentist visit. On the vitals, Her BP shows normotensive, 103, systolic of 103 and diastolic of 76. Her pulse was normal, 68 beats per minute. It was regular and it was symmetrical. Respiratory rate was 14 breaths per minute. SpO2 was at 95% and temperature was at 6.7. No jaundice, no pallor, no clubbing, no peripheral or central cyanosis, no lymphadenopathy, no wasting, no dehydration. It was unremarkable. So on systemic examination, our first system we did was musculoskeletal with integument surgery together. So on inspection, there was no obvious deformities, no obvious swellings, surgical scars on the right calf were noted. She says that it was as a result of bedhook laceration. We found multiple hyperpigmented patches that was scattered in both the upper and the lower limbs of ecchymosis. Secondary to minor trauma, there was no displaced rash. On palpation, there was no tenderness. The limbs, the extremities were warm to touch. There was no temperature gradient. There was no tender or swollen joints, and no crepitus in the joints. CNS, central nervous system, GCS was 15 out of 15. The pupils were bilaterally equally reactive to light. All cranial nerves were intact. The reflexes were intact. Motor was okay. Sensory was intact. Cerebellar was also intact. So unremarkable. On chest examination, there were no chest wall deformities, and the chest was moving with respiration. It was symmetrical. Trachea was midline, symmetrical chest expansion, normal tactile parameters, resonant on percussion over the upper on all the lobes, good bilateral air entry, vesicular breath sounds were noted. There were no added sounds. On CVS, precordium was normoactive. The apex beat was palpable with the fifth intercostal space, mid-clavicular line, no palpable heaves or trees were present. S1, S2 had no added sounds. Per abdomen, the abdomen was not distended, it was moving with respiration. Umbilicus was inverted, no surgical scars or therapeutic marks, no superficial vessels were seen. On palpation, there was no tenderness and no obvious muscles felt. Also, there was no organomegaly. Normal bowel sounds were had, no brew. So that was the systemic examination. So our impression was drug-induced thrombocytopenia in an SLE/lupus nephritis patient. Our differentials were immune thrombocytopenic purpura, and we also questioning hemolytic uremic syndrome. The investigations done for the patient since admission: full hemogram. HB was normal at 11.6 grams per deciliter. WBCs were, sorry about this. I think there's an error here, but the WBCs, there was mild leukocytosis. It was around, if I'm not wrong, it was around 13, around 12 to 13, and the neutrophils were low, so there was neutropenia. So there was mild leukocytosis with neutropenia. The platelets at that time it was 21, so there was severe thrombocytopenia present. ESR, CRP were within the normal range. Metabolic profile done. She had hyponatremia at that time. The potassium levels were within the normal range. TFTs, thyroid function tests were normal. Normal ferritin, vitamin B12, folates, and vitamin, all the parameters were within the normal range. So normal ferritin, normal vitamin B12, normal folate, and normal vitamin, yes. Then the coagulation profile, APTT was normal, it was at 24 seconds, INR was at 1.04 seconds, normal, and platelets was 14.8 seconds normal. Prothrombin time was 14.8 seconds normal. Urinalysis was also done, it was normal. These other ones that are here were the tests that aided in diagnosis of SLE. The HIV, the triple serology tests were negative at that time. As I mentioned in the beginning of the HPI, the patient was diagnosed with SLE with two things: positive ions, that is anti-nuclear antibodies, with anti-double-stranded DNA. So that idea, the anti-double-stranded DNA was moderately positive at that time, 319 microliters. Also, they did a complement assay, so the complement levels were low, especially C3. That's the things that aided in her diagnosis 8 years ago. But current investigations were all within the normal range, except the WBCs, which was, I said, mild leukocytosis with predominantly with neutropenia and severe thrombocytopenia. So how was this patient managed? So the patient was admitted from the rheumatology clinic, and since admission she has received IV solomidrol, 500 milligrams. Okay, so solomidrol is methylprednisolone. Yes, so methylprednisolone IV 500 milligrams for 3 days, and she was advised to continue with her other medications I had mentioned at the beginning of the HPI, the hydroxychloroquine, the aspirin. I don't even know why they told her to continue with aspirin. Professor or anyone else can shed some light on that, because she has thrombocytopenia, and you know the pathophysiology of that, so it's not a good combination. So she was told to continue with other meds as mentioned in the HPI, and that was how the patient was managed. Any question on the history? Any clarification? I'm sorry the slides are not projected, but we will send this presentation later on. Anyone with a question? Yes.
Okay, so you said that the patient is on aspirin, and also the patient is thrombocytopenic, right? Yet our population profiles is normal, right? Is there a basis to question those results?
Absolutely, because I think they only ran once the COG profile, and yes, and the full hemogram, they only ran once. So I don't know if it's sufficient enough to tie it with our presentation. It's subject for debate. Any other question? I think people are satisfied. Either you're not listening well or you're satisfied with the presentation.
Hi guys, it's very sad you can't see our presentation because we took a while to cover. Feeling very bad, but yeah, hopefully the information our care visually. So again, my name is Sandra Opio, 6th year medical student. I'll be doing the discussion part, filling the very big shoes of our professor. So our discussion, the normal layout of how we do our normal discussions in class. So introduction, epidemiology, etiology, pathophysiology, presentation, classification, investigations, management, complications, and prognosis. So SLE, it will be a bit interactive. So are there ideas here? I want to know how much to simplify the presentation. In a very nice way, Akuna, at least for 40 years, anyway, so SLE. Anyone wants to tell me what they understand by SLE? Yes. We atakula kitu wakati.
So my understanding of SLE is that it is a systemic autoimmune disease.
Systemic autoimmune disease. Anyone wants to add anything? Yes? No? So SLE is a chronic multisystemic inflammatory autoimmune disease that the presentation is characterized by a remitting and relapsing phases of protean clinical manifestation. So basically, that's just a fancy way of saying it comes and goes. The manifestations can come and go, and the manifestations can come and go, and they are protein they are very variable. So one person can come with the usual things that the first things we learn about SLE is the malar rashes and all, and other people will come with arthritis, and other people like our patient who presented directly with the lupus nephritis can come with the renal symptoms. Okay, so on epidemiology, so SLE mostly affects women. So there was a study done in KNH in 2019 by Sube and Wambo. I don't know who they are. I hope they are not professors who will listen to me or tell me right, I hope. But yes, in 2019 it was done, and so in our hospital we found out again it was also commoner among females. The ratio is 10:1. The ratio is 10:1, and among women of childbearing age. So the study was done among age group of 18 to 45 years. So the race, it affects Africans, Hispanics, and non-Hispanic Asians. On the causes or etiology, so first we have epigenetic and environmental factors, which are usually tied. So epigenetics is just these environmental factors, they come about and affect gene expression and alter cellular function without modifying the actual gene sequence. So the processes that the type of epigenetic changes we get usually are DNA methylation, histone modification, and RNA silencing. So the environmental factors, the common ones, cigarette smoking, silica exposure, UV light. SLE patients are also tied to Epstein-Barr virus. Then there's the drug-induced, which Najma had mentioned, hydralazine, flukenamide, which are high risk, and then we have some other low risk like sulfur drugs, phenytoin, and others. Also, there was another study done same year 2019, but this one was not in Kenya. But there was a guy called Young they had a lot of vitamin D deficiency around their area, and those people usually presented with SLE later in life. So I just added vitamin D deficiency on the etiological factors. We also have the genetic factors, the HLAs, so DR3, DR4, you will find some DRA1 and many other things in other texts. We also have people who present with complement deficiencies, so deficiency of C1q, C4, C2. We know why I put C4 before C2. Classical pathway. Hormonal factors. So hormonal factors, so hyperestrogen states. So as Najma had mentioned, use of OCPs, oral combined those contraceptives, which the combined ones have estrogen, older women who are on HRT, hormone replacement therapy, and people who have endometriosis. So on the pathophysiology of SLE, so it's primarily innate and adaptive immune response, where we have B cell activation by the T cells. So it's the T cells that are commonly affected, but because that cascade where T cells go and activate B cells to produce the antibodies, that's where the B cell is coming from. So resulting in a cascade of autoimmune reactions that may be limited to single or involve multiple systems. So SLE, that's just the general aspect. So it's a type 3 hypersensitivity reaction, type 2 hypersensitivity reaction, and we also have a mechanism where we have defective apoptosis that leads to immune intolerance. So usually when we have apoptosis or cell necrosis happening, our macrophages and other things come and clear them out. But when they remain there, we get now alteration of these antigens. They come to the cell surface, and then now as nucleosomes, and then now they start getting recognized by the immune system. So they come, they start attacking the cells, and then now, because they're not being cleared, they also start attacking other nuclear antigens of normal cells. For the type 3 hypersensitivity, we know it's an immune complex deposition into the microvasculature. So antigen antibodies, they come, they form a complex, then they go and get deposited. Yeah. Then for type 2, it's directly IgG and IgM that are directed towards the cellular antigen. So these are the main mechanisms also in lupus nephritis. In case you ask how lupus nephritis is happening, this is also what happens there in the kidneys, and then you can also involve the glomerular thrombosis that might be brought about by antiphospholipid syndrome. Yeah. So all these things tied together now promote an inflammatory response by activating now our complement. So now we see where complement deficiency comes in. So activating complement and attracting inflammatory cells, including our lymphocytes, macrophages, and neutrophils. So clinical presentation. So we have our constitutional symptoms, where fever, weight loss, general body malaise, and then we have a very well-known mnemonic to people who have repeated in IMED, or maybe just people who have read about SLE, MD, soap brain, soap MD. I tried to add a few things that might not have been mentioned there. So we have malarash, so MD, soap, sabuni, and then brain. So M, we have malarash, which can be flat or raised, fixed erythematosus over the malar prominences with nasolabial sparing. And then we have the discoid rash, which are usually well-defined, erythematous plaques, with keratotic scaling that may be atrophied. No atrophic lesions are usually lower than the level of the skin, so they can be like that, and they can also cause alopecia if they occur in areas closer to where hair is growing. And then we also have serositis. So these are part of the places where I added things. So for serositis, we know we have pleuritis and pericarditis. So for pleuritis, I associated it with other pulmonary manifestations you can get, like pneumonitis, pulmonary arterial hypertension, and effusion. And then for pericarditis, we can get myocarditis and endocarditis. What do we call SLE endocarditis? Lymphocyte endocarditis. Yeah, basically it's called lymphocyte endocarditis, and it's usually a steroid endocarditis. So you go there, start testing for bacteria, you don't find anything. It's in one of our MCQs. Okay, so oral ulcers. The oral ulcers in SLE are usually painless. We can also get arthritis, like our patient who had arthritis can get arthralgia. The arthritis in SLE is similar to rheumatoid, so it's usually called rheumatoid-like arthritis. So it's usually distal, symmetrical polyarthritis, affecting our fingers, bearing our DAP, and metacarpophalangeal joints and our knees. And then for A, I added alopecia, which we had also talked about. And then we have photosensitivity rash, so you have to know how to differentiate between the photosensitivity rash and the malar rash. So you have to ask whether these rashes worsen or come about with sun exposure and also on exposed surfaces. We also have periangual telangiectasia, so basically just bursting of capillaries around your nails. And then we have blood dyscrasias, which was one, like thrombocytopenia, which was one of the major manifestations with our patients. So we have thrombocytopenia, we have anemia, we have recurrent infections. And then for R, we have renal involvement, and then I added Raynaud's there, which our patient also had. And then we also have anti-nuclear antibodies. As I had said earlier in pathophysiology, our issue is the nuclear part of the cell. That's where these antibodies are targeting. So they are antibodies against these nuclear antigens. So that's why it's called that. And the anti-nuclear antigens should be above titers of above 1 to 80 to diagnose SLE, and you can also have your antiphospholipid antibodies, lupus anticoagulant, beta-2, glycoprotein 1, and anticardiolipin. And then for immunological phenomenon, it's just the anti-dsDNA and anti-SNP antibodies, which are our most specific antibodies. ANA is non-specific. It's very sensitive for immunological conditions, but it's non-specific for SLE. So you can find ANAs in other things. And then, so like anti-dsDNA, as it states, it's antibodies against our double-stranded DNA. And then SNP is targeted towards anti-histone proteins. And then now we have the neuropsychiatric manifestations of SLE, where we have seizures, psychosis, personality changes, and lupus erythematosus. Okay, we are good until then? Now, so we now have, the notes are a bit different, I think. So, okay, so now this is classification. Naona tumejipanga kazi alafu projector inakata. Anyway, so this is classification. So for mild SLE, they just present with our constitutional symptoms, mild arthritis and cytopenias, moderate vasculitis, serositis, rheumatoid arthritis like arthritis, moderate rash and cytopenias or post-1 unresponsive to therapy. And then for severe nephritis, like our patient, mesenteric vasculitis, myelitis, pneumonitis, and severe cytopenias. You can get this from Amsun. Okay, so that's just a diagrammatic presentation of what we've talked about. So for the diagnostics, SLE diagnostics is majorly clinical. So they come with constitutional symptoms and above 2 organ systems involvement. We have this EULA ACR classification, or rather criteria of diagnosis of SLE. You can use it to diagnose SLE, but it's not required, but it will support your diagnosis. And then we had talked about ANA titers of above 1 to 80, and then our antigen-specific ANAs, anti-dsDNA above 200. You can above 800 is a very strong indicator, and then we have moderate, that's between 300 to 800, and then anti-SNP of above 7 units per ml. We also talked about our antiphospholipid antibodies. There they are, you had mentioned them, and then complement levels. So you have to do your C3, C4, and then your inflammatory markers. So inflammatory markers, we have your complex metabolic profile, which you should also do, and your urinalysis. So imaging, it has an eye. Imaging, so joint X-rays for people with arthritis, and then chest X-ray and CT chest for those other manifestations we had talked about in the pulmonary and cardiovascular, and then you can do your echo. So histopathology, you can do kidney biopsy. Najma talked about our patient having type 3 and type 5. So we have that classification with six histopathological possible findings in kidney biopsy. So ours had type 5, which was the membranous one, and then the focal one is type 3. You can look that up. And then for skin biopsy, we have lupus band test. So usually the deposition of this immune complexes in epidermal junction. So it fluoresces on this test. And then you also do your atherosclerotic cardiovascular risk assessment. So basically, people who you think might be at risk of getting cardiovascular or atherosclerosis, there are things you should ask them, or history of diabetes, sedentary lifestyle, those ones. Yeah. So on management, so management, as we have said, SLE is multi-systemic, calling a multidisciplinary approach. So rheumatology, derma, neuro, cardiorespiratory, ophthalmo, and endocrine, and I'm sure there are others. So supportive, so we said we do our ASCVD prevention, which there's smoking, cessation, exercise, diet. Of course, there are other things like our patient who was on aspirin. We've been asking ourselves with Najma all along why they're still on aspirin. We went and checked azathioprine also causes thrombocytopenia. They changed the MMF to azathioprine. So there are a lot of factors that are here. Don't ever forget your nutrition. Those ones are not here, but nutrition, psychosocial support, counseling, those ones must be there in supportive management in whatever condition you are trying to manage. So we have annual influenza vaccines, pneumococcal vaccines. Our patients are very prone to infection, so these capsulated organisms must be prevented. And then avoid UV light exposure, so use protective clothing, use sunblock. I don't know which SPF. And then, so preconception counseling. So preconception counseling and screening. So I saw something interesting that breastfeeding can actually, what is it called? It's protective. So maybe Prof can tell us how it's coming about. So preconception counseling. So contraceptives, we use IUD and progestin only for reasons we talked about, estrogen, no? So you can give low-dose aspirin from week 12 gestation to prevent preeclampsia. Then MMF, methotrexate, and cyclophosphamide are contraindicated. These ones are teratogenic. And then now for definitive treatment, hydroxychloroquine is given to all patients. They have to go for ophthalmic review. I've seen texts saying 6 to 12 months. I've seen one talking about after 5 years, then yearly. So I think it just depends on the patient and the doses. And then moderate disease, you give oral glucocorticoids. So oral glucocorticoids, the ones I'm seeing they're giving here is prednisolone 40 milligrams. Okay, here too, autoimmune 40 milligrams of prednisolone, then I think they have scaled to around 60. I don't know if I've not seen any going beyond that. I don't know. Yeah, then our immunosuppressants, e.g. the one we've talked about, and then there are also others I'll talk about them in severe disease. So for severe disease, we have induction and maintenance. So for induction, we have high-dose IV glucocorticoid. Our patient was given methylpred. We learned a new brand name, Solumetrol. So yeah, and then maintenance, hydroxychloroquine plus a lower dose of glucocorticoid. So our patient was given hydroxychloroquine. He was given methylpred for 3 days, and then they went back to hydroxychloroquine and oral prednisolone. So you can also add immunosuppressants like methotrexate, azathioprine, cyclophosphamide, or biological agents like belimumab and rituximab. Before I get there, specific to our patient who had thrombocytopenia. So the two main reasons for that we were thinking was either drug-induced, which that one was kind of led by the previous treatment she was given, or ITP. So we know for drug-induced we've talked about it, and then we have ITP. So management of ITP, first you have commonly caused by drugs, quinones like this one given, and then Yes. So for treatment of ITP, you discontinue these drugs, and when you discontinue those drugs, like the ones she was given that was causing thrombocytopenia, it's supposed to now resolve spontaneously. And then now there are other things like IVIGs, which you give, and then there are anti-Ds. You give anti-D because hemolysis, so apparently the spleen will start picking the RBCs and leaving you your platelets. So, and then the IVIGs, the macrophage is going to attack the IVIG rather than your platelets. You also can give the eltrombopag and bromoplastin, which are your thrombopoietin receptor antagonists. And then for those who are not getting better, rituximab. Yeah, that's what I saw for the thrombocytopenia. For lupus nephritis, again, I'm trying to go back to our patient because my presentation was majorly SLE, but our patient had specific manifestations. So for lupus nephritis, that I was saying, like, you have to go check this classification of the histopathological stages. Then it depends. All of them are managed differently. And then now for our complications, main cause of death is usually cardiovascular disease in SLE. So acute coronary syndrome, atherosclerosis, Liebman Sachs, and then infections where skin, lungs, UTI, reactivation of TB are common. And then viral, we have varicella, CMV, and HPV. So we also have pancytopenia, osteonecrosis of long bones, interstitial lung disease, and adverse effects to this medication. Our patient was actually on calcium, which I think we attributed to long-term use of corticosteroids. And yeah, I think that's it. But yeah. So with complications of SLE, some of them came in MD brain, so you can play around with them. And then, so prognosis, 10-year survival rate is 90% with treatment. And then, so early disease, so renal, in early disease, the lupus nephritis and neurological complications and infections are the cause of death. And then for late disease, it's cardiovascular, as we have talked about, which is also the commonest cause. Yes, and those were our references. Unedited in case you see a repetition, but yeah, thank you. Do you have any questions? Clarifications, additions, subtractions? Auna?
So the first thing I wanted to say is, first of all, they will differentiate the clinical presentations into mild, moderate, and severe kinds, right? But I've read somewhere they have differentiated it into like a difficult kind and a generalized kind. That's the process. That's that the difficult kind is the one that has primarily dermatologic manifestations on the face. Then on the systemic is the one that has the systemic manifestations now. So I'm imagining if there is a difference in approach to management of the different kinds, which are not
when you go through SLE, like you said, multisystemic, there are other classifications of SLE where there's acute cutaneous lupus, there's subacute, there's the discoid. So these cutaneous manifestations can come on their own like that. So they are usually classified on their own. I didn't go too much into them because we didn't do them, but they're usually classified acute, subacute, discoid. I think those are the cutaneous ones, that's the classification. And then they usually manage also differently. Actually, there's also somewhere I saw this lupus band test is specific to the discoid one. So, yeah, but that's a whole other, that's cutaneous SLE. Even drug-induced SLE is not just SLE, it's also another sub-classification of how you can get SLE. Am I making sense?
So, okay, another question we seem to be asking ourselves is how the thrombocytopenia seems to be coming under right? So and you mentioned hapa mwisho kabisa kuna pancytopenia. Kuna pancytopenia hapo mwisho kabisa. So pancytopenia inamaanisha like a decrease in all blood elements, in all cellular elements of blood, right? So I was thinking probably myelosuppression, the drugs themselves are cytotoxic. The cyclophosphamide has a direct effect, and even the cytokines, the inflammatory cytokines themselves are effect. So here is a point.
Yes, like you said, SLE affects all systems. So it could be from that, it could be from the drugs, it could be from the autoimmune, the immune complexes themselves. Like for example, the ITP part now for thrombocytopenia, because the SLE is actually this actual immune complexes going to destroy those GP2A, 3B, G10, 1B complexes that are used to cause platelet aggregation and adhesion. So there's that, there's the bone marrow part. So it could be a myriad of things, or it could be one thing. So that's the importance of having investigations and a good history. Yeah.
Hello. So about the aspirin and the question of why it was used in the management of this patient. Did you guys ask about the urate levels, the serum urate levels in her blood? Because I was thinking, she presented with symptoms of arthritis, and the idea is that she has lupus arthritis, right? It could be, but it's arthritis. Perhaps, my hypothesis, it could be a stretch, but maybe the SLE somehow damaged the kidneys to the point that it was hard for the kidneys to excrete urate, therefore uric levels rise, therefore you need uricosuric drugs to pass out urate more efficiently. And high dose aspirin is uricosuric. That's why maybe that's what is preferred. Or also, SLE leads to weight gain, which can make someone overweight and or obese. And being overweight and or obese is also a risk factor for acquiring gouty arthritis, which leads to high uric acid levels, which can now explain why it was important to use uricosuric drugs like aspirin. Therefore, if the patient was using aspirin, the dosage is what's important, because if it's low dose aspirin, it's not effective in eliminating urate levels. Yeah, so if it's a high dosage, so it's more effective. That explains why maybe it was used. So the benefits outweigh the risks in terms of the thrombocytopenia of urate. That's just what I was thinking.
Thank you for that.
Thank you very much, ladies, for presenting very well. I want to thank Amsun for inviting me, and I think it was the right thing for them to do. Because I myself was an official of Amsun when I was a medical student. So, and secondly, to start a ground with the lupus is the right thing, and with the rheumatology. You know, there are protein manifestations. There are 2 or 3 diseases with protein manifestations. SLE, syphilis, TB, now HIV, and COVID. And if you seek the knowledge of SLE or rheumatology in general, all the other knowledge of internal medicine will be added at you. Because you know lupus, then you know medicine. But the reason why I stood up and taken this microphone, because I did not want that guy to continue the confabulation. When you're talking about gout, you don't get a 40-year-old lady and start imagining that she could be having gout. You know, there's estrogen that protects ladies from having hyperuricemia. The usage or the maintenance of aspirin in this patient with thrombocytopenia was a mistake, and let's leave it at that and bury it and not continue talking about it. It was a mistake. You don't give aspirin to somebody with thrombocytopenia. Then you don't go on talking and justifying and imagining and saying many things. Sawa, is that okay?
Thank you for the correction. Just learning.
No, you know you can expense land brings too much, but let's leave it there. I think this was an excellent presentation, Najma. Najma made a very good, a very excellent presentation of a patient with SLE, nephritis, and what else? What are the other things? Thrombocytopenia. The question that is what was the cause of thrombocytopenia and how do you treat thrombocytopenia? You know, is it the cat or is it the health? You know, because thrombocytopenia is one of the defining manifestations of lupus. And yet thrombocytopenia can be caused by MMF or the immunosuppressives. But again, the same immunosuppressives are used for treating immune-mediated thrombocytopenia. Are you getting it? Because this patient, to treat the thrombocytopenia, you'd use high dose of steroids, usually 1 milligram per kilogram, and then you give some immunosuppressive agents. You know, to stop mycophenolate and give azathioprine and so forth, it is just juggling so that the patient can see that you're doing something. But it's not very clear whether what you are doing is yielding something. It's just juggling. So, you know, that's the reason. One of the problems with SLE is that it has taken so long, many years, to develop drugs that are specific for lupus. But now we are getting novel medications, such as belimumab is the first one to be developed after a very long time. Then we have rituximab is an off-label indication in the management of lupus, but it is not. It was made for some lymphoma, and it is used more by the rheumatologist. Then you have anifrolumab, which is an interferon 1 inhibitor, and that's what we have. Then voclosporin. So when we're talking about disease-modifying drugs for lupus, we're talking about belimumab and voclosporin. Those are the two drugs that meet the criteria for management of lupus. And we are still looking for more drugs. I think I'll stop there and talking about vitamin D supplementation may decrease this activity, and Sandra was talking about sunscreen. You know, photosensitivity can activate lupus, and then you use sunscreen, usually SPF plus 50. That one. The ones in supermarket are usually SPF plus 20 or something. The ones that people like buying in the supermarket, but the medical ones are prescribed SPF plus 50, going upward. So they are the ones who can protect you from the photosensitivity that comes from after the infrared, the rays that can activate. I think I'll stop there and then just interact with you in form of questions so that we are able to address some uncertainties which could be there. But I think this was an excellent choice of topic because those in 6 years, now that I've sat here, you will definitely, it's not leaking, but I'm just telling you, definitely be this question in I don't know if it's June or where, I know it's July. You'll meet it. But again, that's how it is. The other reason why I was happy to come here, just to come and interact with students, to see their psychology. The 6 years, what is your psychology? Especially when your predecessors have not even been posted. So I want to know. Are you going to join us tomorrow to demand posting letters and budget? I don't know. I'm just asking questions. I just want to interact and see fight of the doom, I don't know. Okay. Any question? Yes.
My question is, I've seen lately they're trying to do autologous stem cell transplants to try and achieve remission or try to treat SLE. What's your experience with this, or can you tell us more about it?
Thank you for that's an excellent question. The other thing about lupus here, the commonest cause, the leading cause of mortality in our setting is not cardiovascular. It's actually infections. Infections, then renal pathology. Cardiovascular, for you to die from surgery, you have to survive for a long time. In Western countries, they survive for long, they get cardiovascular. I'm just waiting by your question. Autologous bone marrow transplant was experimental. But the mortality due to bone marrow transplant was so high in comparison with the mortality due to lupus, and therefore it is not necessary to continue with it. But people are heroic, continue. You know, human beings are interested. People continue, it's nature. If you go through it, it might probably cure. But the chances of dying during the process are so high that it is not necessary. Any question? Any other question? But there are many studies which have been done in this country on lupus. So that's so many. If there's opportunity, I'll give you. But they are outside there. If you go to the African journals online, you find so many studies. Right now, the literature that's being done is the vitamin D levels in lupus and their impact on patient on disease activity. Otherwise, I think this was a good thing. I would continue with these discussions, and hopefully you will make good clinicians in this country if you be given the opportunity. But allow me to mention two things before I leave, because I'll be telling the details. In response to the frustration and joblessness of doctors in this country, there are two things. We have started a foundation of health or medical health professions. This foundation basically is to create an environment. It's similar to the AFIA, it's called what? Equity AFIA. Similar to Equity AFIA, but now to allow train young doctors to come together, train them on entrepreneurship, and they run health services, and within that they generate funds which they can even train themselves further for further training. But this does not remove the advocacy to demand, because you know there's so many doctors walking down the streets who are not employed, but they are not doctors in health facilities. That means that we must also continue with advocating for medical workers to occupy the hospitals instead of filling hospitals with beds and equipment and non-health workers. That's not a good thing. So there's that foundation, there's Equity AFIA, but I also encourage young people to think of the world as a global village. As I stand here, I'm the regional advisor for Kenya for the Royal College of Physicians of Edinburgh. But what we encourage is that once you finish this kind of training, you should also start doing exams so that you fit yourself to where you will be valued. Because a prophet is with the honor except at home. If you find where you are honored, go there and work there. Mungu abariki, tukutane siku nyingine.
Thank you so much, Professor. Some of the presenters have a few questions.
You are missed what I'd like to answer or respond to your question. So, one, aspirin is not erythematosus. Aspirin is given to gouty arthritic patients as an anti-inflammatory. That's the first thing. Now, it's not going to help you remove the uric acid. It's just aiding in the inflammatory process. So that's why it's used in the acute phases, pamoja na colchicine, not in chronic and these other things where we now introduce erythematosus, erythematosus, and their cousin. That's one. Number two, if you have renal failure, you have accumulation of urea. Uric acid deposition, it's a whole different thing. And then for gouty arthritis, the presentation is a bit different. For gouty arthritis, one, so we know, I think in common knowledge, even for someone who's never come to med school, big toe, and then it's usually asymmetrical, unlike these other inflammatories in SLE, rheumatoid, what else? Yeah, and then I think also the other thing, our question was not why the patient is on aspirin, our question was why the patient came with thrombocytopenia and aspirin was not removed. Okay, have I answered you?
Okay, yeah, thank you. I appreciate learning.
Thank you guys so much for listening to us. I thank you.
So, someone has requested we go through the history? Yeah. Okay. All right. Hey, I'm sorry. I want you all, Mwenda his one. Okay, this is a real patient we saw in the Roma clinic. So the patient, just like here to go through kitembea kwa barabara. So this patient, non-rheumatic patient, she has been on methotrexate, which is our first line for disease-modifying agent. Patient reports that she has symptoms of pregnancy. Anakuja anakuambia mimi nasikia nausea, I'm feeling my menses, I'm having a period of amenorrhea, so she feels she's pregnant. So she comes to your clinic 13 weeks after the symptoms. So you're like, okay, she's in the reproductive age, so let me send her to an ultrasound. So you send her an ultrasound, and the ultrasound, there's nothing. Like the ultrasound, there is no gestational sac, nothing. There's no fetal cone, nothing. It's empty. And she tells you, mimi niko na symptoms of pregnancy 10 weeks ago, let's say a month ago, 2 months ago. So what could have gone wrong in that patient?